Well, welcome. We'd like to take you on a quick journey down the power of story, which today is focused on the person behind the disease, but also the caregivers that are involved in treating the disease. So the total focus is really on the role of story. This is a little different than what we would typically do. We're not going to take a long dive into CMS regulations or anything like that. We want us to really take the interpersonal emotional intelligence journey that leads us to how do we engage with patients, their families, and our staff who are engaging with patients and families all the time.
So hey everybody, my name is Nicole Claggett and I am the Director of Community Development at Duke Home Care and Hospice, and I'm also the co-host of a podcast, Edge of Aging. I have been a social worker during my career for over, 24 years now, and have focused the majority of my career on working with geriatrics and caregivers. And I'm absolutely excited about being able to talk about the power of story. It is something that has resonated with me throughout my entire career. Also have been a family caregiver a couple of times, once to a close friend and another time to my grandfather, whose picture you see on the screen now.
So is that you on the far left or you in the middle? Sorry. I'm Cooper Linton. I'm the Associate Vice President for Community-Based Care for the Duke University Health System. That means I operate Duke Home Health, Duke Hospice, and Duke Home Infusion. I'm also the other co-host of Edge of Aging, and we bring that up because a lot of the stories, a lot of the content that you'll hear today has actually been captured through our work on the podcast. Some of it's also been captured through the work with Duke University Health System and Duke Home Health. I also have been a previous caregiver. I helped take care of my father, and then an extensive journey with my mother, who had an unusual form of dementia. And I have no disclosures. Nobody's getting paid for this. Nobody's promoting any products or services. So I think we can get on to the part that you actually showed up for. So where are we going for the next hour? We want to explain and explore the power of story. We really want to talk about it as it relates to patients, but also as it relates to the caregiving staff that are actually developing the relationship with the patients in the first place. And if we value that, we also want to talk about what does it mean organizationally when we want to create a culture that supports people spending time with their patients, unpacking the human patient experience and really taking that where it needs to go therapeutically. We're going to be weaving together a set of stories. As I mentioned earlier, a lot of this was recorded through our work with Edge of Aging, including Dr. Louise Aronson, who's a researcher, physician, author, obviously, of the book Elderhood. We'll talk more about Dr. Aronson momentarily. We also have 3 recordings of patients that these patients were open enough to share with us some very personal things. The first is Tiffany Christensen, who some of you may recall from the Sparks Talk last year, SPRX. Also Jay Reinstein, who has gotten a lot of notoriety recently in a good way. And then the third person is Sherry Thomas, who was with the Association for Home and Hospice Care in North Carolina before she passed away. And Nicole and I had the privilege of literally sitting with her very shortly before she passed away. So we're not just going to share other people's stories. Everybody comes into this room with their own story, and that story ends up shaping the, if you will, coloring the lens through which we perceive everything else. Think back to your own childhood. Maybe it was great. Maybe it wasn't. I have no idea. But it shapes who you are. Think back to your own family, your own social network. You didn't get to pick your family. You have substantially more control over your own social network, so you get to own that one. High school, kind of a mix for some of us.
Happy there was no Facebook back then.
No Facebook, no cell phone, plenty of acne.
Polaroid,
yeah. Yeah, let's just keep moving. College, for me, there was no social media. Hallelujah.
No.
But not everybody went to college. Everybody did learn things. They have their own process of education of how they came into this work. So how did you come to this work? What brought you to it? It probably wasn't entirely random. So how did you come into this, and how does that shape your view of the work we do? Even to the point of how did you come to be in this presentation? Could be you're interested in the story, or you just didn't really like any of the other sessions that were being offered. Well, you never know. But we hope that you'll be interested in the concept of story. The idea of story isn't just reminiscence. It's really the structure of how we learn, how we come to value certain things, and then out of that, how we also teach.
How we connect concepts.
Absolutely. So that they're not stuck out there in the ethernet of our mind, but rather we give some sort of structure and have pins that we can hang them on in our mind. We also look back at our own lives at various points and reprocess things. So our personal story can evolve even if the facts didn't.
Is that how that fish story keeps getting bigger and bigger?
Actually, it was a whale, Nicole. I mean, it was.
I just read somebody did get swallowed by a whale.
I actually read that yesterday. Yeah, people also review their lives before they die. And as they look at how do they try and find meaning, purpose, how do they define value, and what are the lessons they want to leave. We also form connections this way. It helps us bond to others around us. If we think back, there's a great commonality to these human experiences that often bridge faiths, they bridge cultures, they certainly bridge ethnicities. So if we think about parables. Even if parables we typically associate with Judeo-Christian faith, but parables are not in any way isolated to Judeo-Christian faith. Fables, it turns out there's some told by someone other than Aesop, but the purpose of that is to create stories, to help share cultural and common values. If we think about origin stories either of how we came to exist as people, which are often tied back to faith, but we also have origin stories of how did our own family come to be here, or how did I come to do this work, or how did my own family form, or my own network of friends form. We also find wisdom writings, which usually tell a story with a value associated with it. They're the old versions of fables, if you will.
How things got passed down.
It is. Mm-hmm. It's campfire. And if you really think we've evolved beyond that in today's world of social media, I encourage you to put 10 people around a campfire. I guarantee you within 30 minutes there'll be stories told. And it's how we build relationship, and one story forms to another. It's how we build connection. It's how we find commonality through shared experience. It's also how we have the opportunity to reflect on our own personal perceptions, even biases.
And I'll say in some of the staff interviews that we're going to go over later, one of the comments on the side had to do with sharing of stories really made them realize they had more commonality with an individual patient or a staff member than they would have assumed without doing so.
Absolutely. I think sometimes what we see as differences are more visual trappings. And when we get to someone's story, we realize we have an incredible identity and relation with them. So I want us to think about seeking to understand. Seeking to understand patients, seeking to understand the family dynamic in the patient home, both as it relates to the patient experience, also as it relates to the caregiver experience as they engage with that patient and family. I believe it also ties directly to patient and family satisfaction. If I believe that you've heard me and understand me, then part of what is intrinsically built there is trust. And if I trust you, the likelihood of my satisfaction in this experience has no option but to go up. There's also this point, and a couple of our patients will actually talk about this, is the sense of being heard as it relates to their patient goals, their goals for treatment, but more globally, their goals for the way their life runs in spite of their illness. So again, the person behind the disease. So we'd like to introduce the idea of elderhood. Now we talk about childhood. Elderhood may be a newer term, but it's kind of intuitive in a sense. But was actually made more popular by Dr. Louise Aronson. Dr. Aronson is a geriatrician. She's obviously the author of the book Elderhood. She's also an educator, professor of medicine at University of California, San Francisco. Her book Elderhood actually ended up being a New York Times bestseller and was a finalist for the Pulitzer Prize.
That's
so
amazing.
Apparently she's done a pretty decent job writing this. The concept of elderhood is not crazy. It's essentially that if you think about the spectrum of life, we get we're born, we die, we have childhood, we have adolescence, we have adulthood, but the idea that there's a corresponding point in the elder stages of life, starting somewhere, as she says, around 60, 65 years old.
Oh, you're getting close.
60, 65 years old, and continuing on to the point when someone dies. And that we need to think of that part of the life spectrum as having its own unique set of dynamics and values in the same way that we consider childhood or adolescence. And it might be helpful to actually listen to Dr. Aronson for a minute.
A couple of the things I'd love for all of us to be thinking about more is when we think about adulthood, incorporate people in their 20s who have really fast bodies, but a good degree of emotional immaturity and, not so much knowledge. And we don't devalue them for those things. We consider them a work in progress. And then we think of people in their 50s and 60s as among the most powerful people in society, and acknowledge that maybe they're not as fast, but they're also really good at lots of things. And for kids, we accept that we have, neonates and toddlers on the one hand and teens and young adults on the other. And when we look at old age, we sort of reduce it to this few years of debility and disease before death, whereas really it tends to start between your 60s and 70s, and it lasts as long as you live, which increasingly is into our 80s, 90s, and 100s. And I think if we created a world, a health system, care systems that empowered and respected those stages of old age, we would all have a lot more to look forward to. And there would be less, of the drama and dread that we sometimes get associated with old age these days.
So when I listened to Louise Aronson's point, there were two words that stuck out when I was listening to them. She talks about drama and dread associated with the latter stages of life. That's the way we think of it.
Nothing to look forward to.
No, it's not something we want to look forward to.
It's just a mess. It's all downhill.
Right, and we talk about being on the downhill side of life. It's actually an accurate phrase that, or maybe it's an inaccurate phrase, but describes accurately the way we look at it. Her point is that we need to reframe elderhood because the way that we're looking at it now actually devalues the life experience from someone in their 60s and 70s on out.
Yeah. You have a virile 20-year-old who has got all this muscle power behind them, but not a lot of frontal lobe abilities.
They don't have enough sense to get out of the way.
But on the flip side, you have the 70-year-old who maybe can't move furniture around the house, but has a lot of wisdom that they can share to the younger generations.
Well, when I look back at my own early 20s, and I mean that literally, I was usually what was in my own way. Mm-hmm. As we get older, we hope to overcome some of that. And so you swap out this physical capacity for this emotional, social, mental maturity, but we don't seem to value that. We're more focused on taking the car keys and making sure someone doesn't fall, and God forbid Grandpa uses a ladder.
Yeah, about that.
Okay, and I'm not saying that we're encouraging everybody to jump up on ladders, but my point being that we're not giving value to that ladder spectrum, and because of it, we're devaluing their story. We don't listen to the wisdom. We don't seek the wisdom and perspective that they bring.
And it's because of how I think it's because of how we act, where we place value in the society.
Well, and this isn't the same for all cultures. Some cultures value the aging population very differently than we tend to here in the United States, in this culture that's fixated on being young,
Right.
which I'm not doing very well. So Dr. Aronson has another clip that we're actually going to share with our guests here in a moment, where she makes an interesting distinction, and one that I had not made before. We talk about medicine and healthcare as if they're interchangeable.
Mm-hmm.
The healthcare system, we provide medicine, we talk about schools of medicine. But she makes the point that medicine, the focus of medicine is on the disease. Healthcare, if it's done correctly, is focused on the wellness of the person who has the disease, which then begs the question, how do we know that person? What does their wellness mean? I take this as another point to why we need to understand the human narrative, the human story of the person whose wellness we're seeking out.
So what would you say the healthcare system as a whole, if you look at the national healthcare system as it relates to, how hospital systems and physicians' practices and even the community-based care, how could we work better together to properly care for our elders?
Ooh, such a good question. I think we have to recognize that you can't really provide great care to an elder if you don't think about their functional status, for example. And actually, I might argue that for all of us at all ages would enjoy our care more if it recognized our individual needs and priorities. But among the things that distinguish geriatrics are really thinking about who are you? What is it you want and need to do in your life? And how can we help you do that? Now, our medical system currently works more on disease. And we sometimes use the words medicine and healthcare as interchangeable, but they're actually different. Medicine focuses on disease, and healthcare, and a lot of the community-based systems are much better at this than the so-called healthcare system, focuses on health and well-being. So I think we can, if the healthcare system recognized that it's not that social care, that social interactions, that functional care, that things, everything from physical therapy and social work to just having human connection, which we know makes people healthier and more functional, are an absolute part of health, and that health matters as much, if not more, than disease treatment. Because if you could actually keep people healthier, they don't need disease treatment. And that's part of the problem, because the structure, the payment structures now and the power structures are all aligned towards disease treatment, which means let's let you get ill. Let's let you develop disabilities instead of let's help you to thrive as long as possible and help you once you're ill and disabled. So I think if we could somehow figure out a way to further empower the community structures that are so essential to helping people be healthy and functional and thrive, and to not have them be, as they so often are, second-class citizens to the medical system, we would have more health and more highly functional elders. Because we also do know that people with more social connections are much healthier, and people who get regular exercise and functional improvements are much healthier and happier. And we sort of live in this world where we complain about how much healthcare and how many needs elders have as they move through elderhood, and yet we do everything possible to push them into a dependent role instead of to help them thrive as they get older, which is completely feasible.
So one of the things that I thought Louise said that really struck me was about the fact that we really place older adults in a dependent role. So a little bit earlier you were talking about, and I kind of chided you about yelling at Grandpa for going up the ladder. But I do think we have a very low risk tolerance when it comes to older adults, and we don't really allow them to do as much as they can do to kind of stretch those boundaries, just like with little toddlers, right? When they're walking, we watch them fall, and I know they're made of rubber when they're little. And I'm not suggesting we watch an elder fall.
Weeble walls. So I'm torn on this.
Yeah.
I really am, and I think my guess is our audience is also torn on this. There's this idea that we're tracking patient falls. I mean, most of us are tracking patient
Right.
falls. We do it every single day.
Yes, I guess.
We talk about patient risks, harms,
Yes.
this whole commit to zero concept that the
Uh-huh.
Joint Commission is driving, and which should be our goal. We shouldn't be in the business of causing harm to people. But when is it we're not causing harm and we're allowing somebody to make choices? And to your point, our risk tolerance for them may be substantially lower than their self-risk tolerance. Do we hear them? Have we understood what they want for them? Do they want a zero-risk world?
Mm-hmm.
Or do they want some sort of blended, mitigated risk? Because you're going to fall, you're going to break a hip, you're going to go to a nursing home and die. How many times have we
And
heard?
a big problem we have in this country is the whole idea of the helicopter parent. So are we now doing that? We're doing that to our children, which creates a
So
whole
do we
set
have-
of issues. Are we doing that now to our parents?
It's a helicopter caregiver.
So
Did we understand what they want? What is their story? What is their goal of care? And I think you're onto something when we talk about risk tolerance. I think it's also important that Dr. Aronson refers to that the idea that there appears to be a lot more physical resilience in the older population than we sometimes give them credit for. But we have to be focused on their well-being as opposed to focusing on the disease. And I think she also makes some pretty valid points around the structure of healthcare policy and payment.
to allow that.
Right. I mean,
Or to encourage it.
the current model pays for us fixing things when they go bad,
Yeah.
not keeping things from going bad. So it's an interesting concept, but it requires us to understand what the person wants as opposed to what we want for them, or more often, what we don't want for them.
Which is informed by their story.
What's absolutely dependent on it.
So we've had the honor of talking to Jay Reinstein over the past couple of years, and he actually has agreed to allow us to interview him throughout his Alzheimer's journey. He has younger onset Alzheimer's disease, and
Sometimes called early onset.
Sometimes,
I
yeah.
don't think that's really as accurate. But
yeah. And, when we first met him, he was pretty recently diagnosed and had just left his job. And now he has really used his voice to make a difference and make a mark on Alzheimer's disease, and really try to, I think, get rid of some of the stigma.
There's a courageousness in Jay that is inspiring to me when I hear him. When you realize his story, and I mean, he was in a very influential role in local government that dealt a lot with policy and coordination of public policy and business, and was the assistant city manager for Fayetteville. Yeah. I had 20-some years of municipal management. This is a guy who's very formative to the work that's going on in central North Carolina. And suddenly is facing the fact that his cognition is not what it was. He was the one that noticed it.
He was, yeah, he'd be in meetings, and he would suddenly not be able to remember what was on the slide decks or the presentation he was going to give. And he made a decision to go public when he was diagnosed.
And then doubled down. He really took a next step and decided he was going to step into a role of advocacy related to these relatively small percentage of people who have younger onset Alzheimer's. It's about 5% of the total population of Alzheimer's patients, and is now the only person with Alzheimer's that's on the board of directors for the National Alzheimer's Association.
That's right. So he's using his voice, and I think he really underscores what Louise Arneson is trying to teach us.
Well, let's let him tell us.
So one of the things that we do wrong in healthcare, and it's one of my biggest soapbox issues, is we define a person once they get into the system by their diagnoses, whether they're diabetic, have cancer, have Alzheimer's. And really, we really need to be looking at the whole person and who they are, because this disease doesn't define you. It's giving you a platform, certainly, to make a difference for others. How do you think we can go about changing that paradigm?
I think it's important to talk about what that person is still capable of doing, the capabilities. Focus more on the capabilities as opposed to the liabilities, the deficits, that there are many things that I can still bring to the table, whether it is being able to volunteer for a certain organization, working part-time, maybe doing something a little different than I've done previously. But again, it's trying to demystify the stigma of early onset Alzheimer's and Alzheimer's generally speaking. And I think by letting people see folks like me functioning and successful in life, I think can really inspire others. So again, it's focusing on what we can do, not what we can't do.
If you had a message for healthcare providers in how they engage with you or how they should view you, what would you ask of them?
Don't judge me. Get to know me. Get to know what I can do. Get to know what we can do, what the value that we can add in society. We have a lot that we can offer. And I think if you put us under that umbrella with early Alzheimer's and you send that message that we can only do one thing, then I think you really are doing us a great disservice.
So when I listen to Jay, it's interesting to me how he breaks down how he wants to be thought of. Don't define me by my liabilities. Define me by my capabilities. Focus on my capabilities. And don't limit my value and my role to only being the guy with Alzheimer's.
And Jay's not in elderhood, but I think he can teach us a lesson.
He's got this weird spot. Chronologically, he's not in elderhood.
Right.
But he has a disease that's
typically associated with
95% of the time is in elderhood. Tiffany has a really incredible story. Her personal health journey is incredible. Some of the folks today will remember her from the SPRX Sparks talk that we did last year. So Tiffany has a disease where she needed a lung transplant in her early 20s, and that lung transplant failed. And she ended up having to get a second double lung transplant. So she's now on her third set of lungs in this world. At the time that we were recording her, she was also had come out of very recent total kidney failure and was waiting on a kidney so that she was waiting for her third organ transplant. She has a really unique perspective. And the goofy thing or the ironic piece of this is she's the vice president for patient experience at the Barrel Institute. If there's anyone who gets it, she certainly has a lens through which to
bird's
see.
eye view.
Yeah, it's first eye view. Yeah, she is. She's truly been in it and has been in it for over 20 years at a personal level. So I think our guests are really going to enjoy hearing her and seeing some of the relationship between her thoughts and those that we just heard from Jay.
I was actually driving over here today, realizing that because of all that I'm going through physically right now, my voice is weird. It's a little weak sounding to me. And I was worried about that. And I was like, oh, I'm going to sound weak. I'm not going to sound very smart. And I realized that is a great sort of metaphor, in a way, for illness, that our internal life can be as strong as the day we were born, even if our physical body is weak. So my voice is weak, but my internal body is the same, and it is as strong as it's ever been. And that was the same for me when I was very, very sick in the bed a few months ago. That's the same for me when I was very, very sick waiting for my lung transplants. My internal fire, my internal body or self doesn't change like my external body does. So one of the things that I hope healthcare professionals will recognize is that just because that external body looks a certain way, that doesn't necessarily reflect the internal life. We hear you, we're listening, we're participating within ourselves. We may just not be able to physically express that. And when you, as a professional, recognize that, that means the world.
So in the first clip, we hear Tiffany talking about the concept of medical intimacy. There's that exchange about what is medical intimacy, what is the concept of knowing someone's journey. In the second clip, what we get is who is the person that knows that, and how do we get that information from the patient or the patient's family back to us as medical providers.
And sometimes maybe that caregiver is the medical provider. So let's hear what she has to say.
Perfect.
Somebody who lives with me or somebody who spends a lot of time with me as a person understands things that no one else can, because I'm not reporting everything. I couldn't, even if I wanted to, and B, I'm just simply not going to. If I have, a day where I'm in bed with nausea, for example, I'm not necessarily going to call my doctor and say, hey, I'm in bed with nausea. But my person or people who are medically intimate see that. And so they start to see patterns. They start to see, oh, this worked for her, or oh, this didn't work for her, or oh, yeah, that every time she gets that med, that's what happens. And so that level of deep knowledge, that level of walking beside a patient is a treasure trove of information. And if you're not digging into that treasure trove, you're really missing a huge opportunity to create partnership and to do better in terms of taking care of that patient.
It's medical intimacy.
Yes, I love that.
That term gets used in a way that's not at all the intention here, but it requires that someone knows the details. They know not only what happened, but they know what you experienced when that happened.
Oh, that's a beautiful phrase. I'm going to steal that. I love that. Medical intimacy. Exactly.
And that it requires an enormous degree of trust to share that. I don't think so. Let me preface this. We talk about having these conversations with our doctors, and I think sometimes what we're sharing with our doctors are the tasks.
Yes.
The actions. I want you to provide an IV in this circumstance, or an intubation, or not provide intubation in this circumstance. Those are the verbs of the work, but they're not the emotions that you want someone to know about you when they're making that decision on your behalf.
Absolutely. It's clinical preferences versus the experience that got me to make those preferences.
So there's two clips that I think we want to share with people. And I don't know that there's going to be a lot of need for you and I to curate these two. One is from Sherry Thomas, as she talks about the fact that we need to have conversations with people about their wants, even if that includes the latter part of their life and end-of-life discussions. I think it's incredibly important to understand that Sherry shared this just a couple weeks before she died.
In her final days.
She shared this with us. It was very powerful to hear her speak of this, because she said, I will not miss this opportunity to educate, knowing that it was very much an insight into the last part of her life. So we're going to hear that, and then we will move to Tiffany Christensen again, as she talks about that we also make decisions too late, and what should we be focused on in those conversations. Again, understanding the person behind the diagnosis, the person behind the disease. I think let these stand on their own?
Yeah, I mean, I think, and Tiffany talks about that with the eye of facing death multiple times in her life.
Right.
And how people in her life have not helped her with some of those much needed courageous conversations.
The two women are coming at this from very different life experiences. One who's young, who's faced death multiple times. One who still died too young, at least for me, but is facing this as a one-time event.
So it sounds like you do have a very unique perspective, being that you've been a public health nurse for all these years and now receiving hospice care. Do you think that there is anything that the rest of the healthcare continuum can learn from the type of care that you're receiving now that would help people further upstream?
Absolutely, and I hope we're seeing more of it, but I think it's just beginning the conversation and not being afraid to broach it if you see a patient at that situation in life, because they may not have thought about it, they may not have even thought about end-of-life care yet, and I think it's knowing that you can start that conversation with patients in a very compassionate and caring way, and they may very much welcome it rather than be afraid of it. And I think that and that can be started in many different ways. It can be started when that patient is a patient already, or it can be started as this hospice house does, by reaching out to members in the community, doing education at different venues and events, so that it just plants the seed and then lets people start thinking about what they really would want. And I think that's something that needs to change. It's just not being fearful of the conversation and knowing that it's not a death talk. It's not anything that should really scare someone off. It's just another conversation about choice, and that's what we need at these times, is the information that we need to make good choices for ourselves and be involved in those choices while we still have the capability and capacity to be involved in those choices.
We are so sterilized in this culture and in this country when it comes to end of life. When I used to work at Duke Hospital, and when I would walk through the halls of the ICUs and I'd see these patients attached to every tube that we could possibly put in them, it looked to me like torture. And I used to think, I wish that we could show this to people, because of the fact that it's HIPAA and because of the fact that people are uncomfortable and they don't really want to talk about this stuff anyway. We reserve that for the moment that it happens. And that's the absolute worst moment, to be making decisions and to be understanding, oh, this is what we mean by life-saving treatment or end-of-life palliative care even. So I wish that we were more transparent in this culture about what the realities are of our treatments that we offer. And I wish that we were more willing to have conversations with each other about our fears, about what we value in life, what we hope we accomplish. There's a lot of assumptions made about what people want in terms of, this idea that people want to live no matter what. And I don't know that people are really given the option to really think that through.
You actually have a choice.
Right.
Just like you got to make a choice about, and you were grappling with the choice about whether or not you even wanted dialysis if the day ever came.
Yes. Yes, I mean, that's a great example. This idea of shared decision-making that we talk about in the world of patient experience isn't always as transparent as it could be. So, for example, when my kidney started to fail, I was given two options, transplant and dialysis, but they left out the third option, which is death. And that's a valid option. And I couldn't decide if I wanted transplant and or dialysis without deciding first if I wanted death. Because if I wanted death, then I don't really need to explore these other options, right? And I'm young, but I've been through a lot. My body's been through a lot. And to say that I should go through more really invasive treatments is not fair, I don't think, to me.
As we listen to Tiffany, there is a almost stunning candor for me where she talks about her three choices.
The doors.
The doors, as she would talk about, yes, where she starts looking at, transplant as an option, ongoing dialysis as an option, and then death as an option, and the need to have her voice heard. And the deciding factors for that really were not medical decisions. They were the person, again, behind the disease that begins to come out.
What more does she want to go through? What does this mean for her life? What kind of quality of life will she have?
Absolutely. And understanding her personal story. And she's a woman who's in her mid-40s, not who's facing this in her elderhood years. Mm-hmm. If we think back to Louise Aronson's work, she's having, if Jay has younger onset dementia, Tiffany has younger onset elderhood in a lot of respects, which is a part of her story that has to be woven in, that goes beyond her diagnosis, goes beyond the transplants, and goes beyond the options, because they're the part of her that informs the options.
And because of her professional role, I think she has an incredible ability to have this perspective where she knows what it feels like to be that patient. And she's very vulnerable and honest about that experience. But she also has the ability to say, hey, let's zoom out, big picture. What do we need to do to actually better meet the needs of the patients as individuals, as professionals, and from a systemic perspective? Let's hear more about that.
Sounds good to me.
It's going to sound really, really simple, but it's really, really hard. Listen more than anything. I mean, listen on a lot of levels. So listen literally. Mm-hmm. We know now from our most recent study that physicians interrupt patients, I think it's 20 seconds into answering the question, what brings you here today? So literally listening, letting me finish my sentence, even when I can't get the words out. I had a experience when I was in the hospital of trying to talk to somebody who was going to do the procedure to put this in. And I was cognizant. I mean, I knew what I was saying. I just couldn't say it. And he kept interrupting me, and he was getting it wrong. He wasn't finishing my sentence correctly. And so I finally said, I know it's frustrating for you to listen to me talk because I'm having a hard time cognitively, but if you could please have patience. I know what I'm saying. And he finally, oh, okay. And he listened. And then we were able to have a constructive conversation. So literally listening, but then also this idea that Brian Stevenson talks about of getting proximate, meaning actively seeking out what is your perception, your experience, your perspective, where are you coming from, where have you grown up, what is your background, what is your culture, all of the things that are going to inform the way that you behave and react to me in this moment. Let me get proximate to that so that I can actually work with you in a way that is most beneficial to both of us. It's not about just the patient. Isn't it more satisfying for a clinician to be able to work with people who are now understanding partnering with, working to the best and the highest degree of their, getting intimate. Yeah, proximate, intimate. So for me, listening is the key piece for that piece as well. And then finally, as an organization, how do you listen? How do you integrate the voices of patients and families into policy design?
So I really appreciated what Tiffany had to say, especially when it got to talking about changes in policy. I think we really need to look at what can we do as a system, as a healthcare system, as a medical system, perhaps, as Louise Armanson would say, to really change the paradigm on how we approach patient care and how we approach listening. And that may not intuitively mean more visits. It may mean less for better outcomes.
Well, in home and community-based care, we've spent years, that's not true, we've spent decades counting visits. No one could count visits and track mileage better than home and community-based care. We are experts at it.
Lawyers, maybe?
They typically do it 6-minute increments, so yeah, they may have us beat. The question for me becomes, is that what we should be measuring? And by measuring that and incentivizing that, are we shifting away from giving our staff the space, the time that they need to build relationship with patients, to hear the stories, to hear the caregivers, the treasure trove of resources.
To become proximate.
To become proximate. We're not asking them to step into the role of medical intimacy. That's a boundary issue. But to have time to unpack that from the patient, from the caregiver, to help inform the care plan, that is our role. There's also some interesting study out there, and every now and then you get a study that's very timely. There's an article in the Journal of Patient Experience from just last year. So it was published during the age of COVID. But it talks about how patient stories can make a difference in patient-centered research design. And there are 4 elements that came out of that. One was establishing mutual understanding. Well, that's kind of intuitive. The other is adding expansion and depth to the patient story, to the engagement. The third is characterizing abstract concepts. Well, I think that's where story has always taken abstract things and actually tried to make it concrete and real and relatable, which brings us to the 4th item, which is they found that these stories provided context for experience. If we understand the patient's context and understand their experience, do we then change the way we engage with patients in the home? And I think we have a really unique opportunity in home and community-based care. Unlike facility-based, we're in their space.
Entering their world.
Yes, we truly are. We're guests in their home. And there's an inherent greater likelihood to begin to share when it's their space that we're in. What I'd be interested in doing is, we have had some interviews with some direct caregivers.
Yes, and they were very brutally honest.
Well, let's hear them.
That connection is one thing I thrive on. The patients appreciate, the continuity and knowing that they have somebody. But it's harder in the home environment because you're in their home. That barrier that you have in the hospital where, they're on your turf, it's the exact opposite. You're on their turf. So keeping, appropriate boundaries, can be challenging. But I think if you don't develop a connection, that almost defeats the purpose.
In the hospital, you really don't get that follow through, that closure of what happened with the patient. And it's so nice to have that in home health. I mean, you can really see what you're doing matters.
It's impossible not to get a connection with your home health patients. You have to keep it professional, but being there with them so much. Some patients we see 3 times a week, and I've had patients, my longest patient I had for about 8 years. I think it's a good thing. You have to know where to draw the line and how to keep it professional, but you definitely get close relationships with your patients. Home health is so important because our patients thrive at home. They get better faster at home when they're able to be in a comfortable environment as opposed to being in the hospital and woken up around the clock for vital signs and things like that. Home health is definitely the best place for our patients. Being able to keep your patients at home, which is their optimal environment, is wonderful and rewarding in itself. And home health, being able to provide that holistic care for your patient, is great as well. It's really rewarding.
Healthcare is fast now, and healthcare is seeing a lot of patients in a day. Providers are constantly strained to see more and more and more, and all healthcare workers are very busy. It's important to take a moment to connect with a patient. It's maybe a patient has trust issues with a clinician or a provider based on a previous experience. Who knows? But your ability to connect and to empathize and to get that patient to trust you could mean the difference of you finding out a vital piece of information that could help you take care of them. And that can be done with as simple as a smile or just asking them how they've been feeling and about their day or what's something that they like to do, and helping them look to a brighter day. I found that helps me create rapport with a patient, and then sometimes they'll open up and tell you something that's critical to providing care to them.
Listening to the voices of our staff, and I'll be personal, those are the voices of the people on Duke Home Health and Home Infusion's team. There's a weight that comes out of that for me. There's a challenge that comes out of it. Are we supporting our staff in a way that gives them the bandwidth, gives them the freedom within their work and their work expectations to begin to explore patient story, to get proximal, to borrow the language from Tiffany? How well are we doing that? And as an industry, how well are we doing that? What opportunities are here for us to unpack that?
I think for me it was incredibly validating to hear those words from the clinicians. As a social worker working in the industry since the mid-90s, when I talked to people that were happy with their jobs, and when I talked to residents or participants or clients or patients or whatever I called them throughout my career, depending on where I worked, those folks that connected with those folks were always the happiest. So I think, we're starting to recognize, just like we're recognizing the need for things like support of a family caregiver, I think we're also starting to recognize what we need to do to keep the body of clinicians that we have happy and retained, and also what do we need to do to create a better experience for those that we're serving? Because as the baby boomer population continues to roll into elderhood, most of them are really not wanting to move into long-term care facilities. Most of them are wanting to age in place and home.
Sure.
And so how do we attract a workforce to do that work, which is a lot of driving around? It's not an easy job. And then how do we keep those folks in the home feeling like they're having their needs met and that their stories are actualized?
I think there's a beautiful convergence. We have patients who want their story told, and we need to understand their story in order to do a better job. That leads to better satisfaction, better family satisfaction, better patient experience, and alignment between the care plan that we craft and the desires of the patient to make sure that care plan matches what they want. It also matches up with what we're hearing from staff that say, I need the freedom, the time the capacity to connect to my families, my patients, and it's one of the places that I draw the most satisfaction from. You know, I hear the argument made, well, I don't know that we have time under our reimbursement, that we can afford the time to allow that much visit experience time. I would make the argument, maybe we can afford to do nothing but that. That if we don't allow our staff to make that connection, we're going to lose them. And we're also losing the very essence of what they're capable of producing in the home. And we're going to have to zoom out a little bit and make this happen.
And I will say, you know, I've had the honor of working on a project for the team, and 100 times out of 100 times that I've interviewed the clinicians about what keeps you coming back, what do you think about when you've had a hard day, it's 100% a patient story. It's a moment that they had to connect with the heart with somebody else. While sometimes it's exhausting to go through those, upon reflection, those are the things that keep them coming back. Even when they leave to maybe try something in a more acute setting,
Right.
They come back because of those stories.
No one's going to stick around because we gave them a 5-year pin for their badge, or we gave them gas cards or car washes. And I mean, it's fun. I think it's fun to do some of that and
Right.
to reward people. But to your point, what fuels them every day? They got into this work because they also have a human narrative they want to connect to. And they want to combine their humanness with their professionalism. And I think more than ever, our patients need that voice to be heard. We got some work ahead of us.
We do.
Well, it's been fun. We appreciate these folks sharing their stories with us.